everyone. معاكم دكتورة آية الجزيري clinical pharmacology staff member. هكلمكم النهاردة على one of the most important drug class, which are anticoagulants, one of the antithrombotic agents. The intended learning objectives of this topic are going to be classification of different antithrombotic agents according to their major objective of use, according to their major indication of use. And we will define the anticoagulants and then classifying them according to the route of administration and the mechanism of action. We will also justify their clinical indications according to the seriousness of adverse effects and based on its use either for short or long-term use. And lastly, we will contrast the advantages and disadvantages, or the merits and limitations of their different classes according to the pharmacokinetics, absorption, distribution, and excretion, according to the pharmacodynamics, according also to the monitoring need, and any existing contraindications and interactions. Antithrombotic agents can be classified into two major groups. The first group is the drugs that can limit the thrombus formation and progression, and this includes both anticoagulants and antiplatelets. The anticoagulants works by inhibition of the further progression of venous thrombi and emboli. However, the antiplatelets inhibit the progression of arterial thrombi. So it decreases the coagulation factors or the platelets to limit their ability for formation of blood clot or thrombus. The other group of antithrombotic agents include the drugs that enhance the thrombus lysis, that degrades the thrombus inside the artery or the vein, and they are called fibrinolytics. So fibrinolytics هم الدراجز اللي بتعمل degradation للexisting thrombus. إنما anticoagulants and antiplatelets, they prevent the further progression and enlargement of the size of the existing thrombus or embolus. We have to talk about the coagulation cascade first, and then we will, upon it, we will classify the anticoagulant drugs. Coagulation cascade is either extrinsic pathway, which is initiated by tissue injury, upon which tissue factor is produced, and it will activate factor 7 to factor 7A, which will act on factor 10 to produce an activated factor 10A. And this 10A, the active 10A factor, will convert the prothrombin 2 to thrombin 2A. This is the role of extrinsic pathway. Also, the factor 10A can be activated through another pathway, which is the intrinsic pathway. Intrinsic pathway is initiated by blood vessel injury, which will activate factor 12 to 12A, which then converts factor 11 to 11A that acts on factor 9 to 9A. 9A stands for activated. Factor 9A together with factor 8A will act on factor 10 to produce factor 10A. Factor 10A in conjunction with the factor 5A, which in a calcium dependent manner also activates the thrombin 2A. And then this thrombin 2A will act on the fibrinogen to form the soluble fibrin monomer. We need an insoluble fibrin polymer to make a stable plaque, and this will be achieved through the activation of factor 13 to 13A, which then activates the fibrin polymer. Therefore, factor 10A, we can notice now, and it's the most important factor in the coagulation cascade. So we can now classify the anticoagulants according to the route of administration and mechanism of action. هنبدأ بالmechanism of action. They can be classified either to indirect anticoagulants by inhibition of thrombin and coagulation factors such as factor 10A, but not by binding to the factors itself. No, they inhibited through binding to antithrombin 3, an endogenous antithrombin 3, which is normally inhibiting the coagulation factors, but binding of these indirect anticoagulants to antithrombin 3 will accelerate and potentiate its effect on inhibition of thrombin and coagulation factors. And direct anticoagulants that directly bind and inhibit the coagulation factors, and vitamin K antagonists which inhibit the synthesis of coagulation factors by the liver. An example of these drugs, the vitamin K antagonist is the warfarin. The direct acting anticoagulants or the direct thrombin inhibitors such as bivalirudin and dabigatran, and factor 10A inhibitors such as the rivaroxaban. The indirect anticoagulants are like unfractionated heparin, low molecular weight heparin or enoxaparin, and fondaparinux, which also binds to antithrombin 3 but inhibits the factor 10A and doesn't have any effect on thrombin. To sum up, هنا unfractionated heparin binding to the antithrombin 3 will inhibit both thrombin and factor 10A. However, unfractionated heparin inhibits thrombin more. A low molecular weight heparin inhibits the factor 10A more than thrombin, and fondaparinux acts only on the factor 10A and does not inhibit the thrombin. And speaking of the direct factor 10A inhibitors, the rivaroxaban, it binds directly to factor 10A and inhibits it, and the direct thrombin inhibitor, the dabigatran, binds directly to factor 2A or thrombin and inhibits it. These two drugs, keep in mind that they are called the NOACs, the new oral anticoagulants, the rivaroxaban and dabigatran. We will talk later about these NOACs. So the factors inactivated by anticoagulants can be summarized as follows. By the inhibition of antithrombin 3 by heparin and low molecular weight heparin, these factors, the factor 12A, 11A, 9A, 10A, and thrombin 2A are inhibited. And by the binding of direct thrombin inhibitors, thrombin 2A is inactivated. Factor 10A inhibitors inhibit the factor 10A activation and the downstream cascade is inhibited. And vitamin K antagonist inhibits the coagulation factors 2, 7, 9, and 10. The other classification of anticoagulants is according to the route of administration. There are two routes of administration for anticoagulants, either parenteral or oral anticoagulant. Heparin, unfractionated heparin, is given parenterally, only parenterally, and warfarin is given only oral. Low molecular weight heparin is given subcutaneously or IV, the enoxaparin, or the directly thrombin inhibitors, including the bivalirudin, which is a reversible inhibitor, is given parenterally. However, the direct thrombin inhibitor, dabigatran, is also reversible but is given orally. Factor 10A inhibitor, the fondaparinux, is given parenterally, and the direct inhibitor, rivaroxaban, is given orally. So, the direct inhibitors has a drug that can be given parenteral and a drug that can be given oral, and also the direct the 10A inhibitors has a drug that can be given parenteral and the other can be given orally. As we have mentioned in the previous slide, dabigatran and rivaroxaban are called NOACs. Also, we have to keep in mind that heparin does not have an effect on the fibrin-bound thrombin. So, unfractionated heparin cannot bind to fibrin-bound thrombin. Bivalirudin, only the one that can bind to fibrin-bound thrombin. Fondaparinux cannot bind to the fibrin-bound thrombin, neither the vitamin K antagonist. So this is important concerning something called HEAT, the heparin-induced thrombocytopenia thrombosis, that we are going to talk about later. A very common side effect of unfractionated heparin is the heparin-induced thrombocytopenia, HIT, or heparin-induced thrombocytopenia with thrombosis, HIT, which with two T's, HITT. It can happen if the heparin is given the first time. The manifestation will be at least after 5 to 10 days. And now لو في previous history of heparin intake before, it can appear in less time as already there is antibodies are formed. هو عبارة عن immune reaction between there is an antibodies that will attach to the heparin, forming an immune complex. This immune complex will attach to the Fc receptor of platelets that will lead to platelet removal by the splenic macrophage and degradation resulting in thrombocytopenia. Patient في التحليل بتاعته هتلاقي thrombocytopenia. If it's accompanied by compensatory platelet activation, it can increase the platelet aggregation and leads to thrombosis, and this will be called HITT. What to do then? Heparin must be withdrawn, and we give a direct thrombin inhibitor that will act on the thrombin bind to the fibrin that is inaccessible to the heparin. On long-term administration, heparin can cause osteoporosis, can cause necrosis, hyperkalemia, reversible alopecia, but it's kind of rare. The contraindications, of course, it cannot be given in patients with active bleeding, active GIT bleeding or intracranial hemorrhage. If there is a bleeding disorder, such as who is already having thrombocytopenia or hemophilia disease, or there is a hypersensitivity or history of HIT, or there is a severe uncontrolled hypertension. The second drug that we're going to talk about is the enoxaparin, the low molecular weight heparin. Low molecular weight heparin is a short chain of the polysaccharides, and is derived from the regular unfractionated heparin. It differs from the unfractionated heparin in that it has a greater affinity to factor 10A inhibition, and it's given subcutaneous with a longer duration of action. It doesn't have the variable response of heparin. It has better bioavailability and predictable response, so no need of regular monitoring. So what is similar between the unfractionated heparin and enoxaparin is that they have the same indications, but it can be given outside the hospital. Heparin has to be given inside the hospital because it can cause bleeding and it needs monitoring, and it has variable response. However, enoxaparin can be given outside the hospital due to the better bioavailability and the predictable response. The same adverse drug reaction of bleeding and what we have talked about, but it has less hemorrhage and HIT susceptibility. The contraindication is also safe in pregnancy, such as unfractionated heparin. So pregnant women can take either heparin, unfractionated heparin, or low molecular weight heparin. Coming to the factor 10A inhibitors. Factor 10A inhibitors, they inhibit factor 10A through directly binding to it. So it inhibits consequently the thrombin generation, either indirectly by the binding to antithrombin 3, and this drug is called fondaparinux and is given parenterally. It has excellent bioavailability and long half-life, so it's a very good pharmacokinetics that it can be given only once daily. Or the inhibition of factor 10A can be also attained through the direct binding to the factor 10A itself, such as the rivaroxaban. It has bioavailability with increased bioavailability with food administration. It has a short duration of action, so it can be given once or twice It is metabolized by cytochrome P3A4 and transported by P-glycoprotein. Rivaroxaban is one of the NOACs. Again, we're stressing on these points because they are the most commonly used anticoagulants now. فهتسمعوها كتير النوعكس novel or anticoagulant drugs. What about the uses? Factor Xa inhibitors can be used to control the HIT or HIT thrombosis, but it's contraindicated during pregnancy. Also, renal functions have to be assessed before giving, because if creatinine clearance, if there is severe kidney injury and creatinine clearance is less than 15%, it's absolutely contraindication because it is excreted mainly by the kidney. It do not need a regular monitoring. However, there is an anti-factor Xa sometimes are done, but not in all facilities, so on. It's very expensive. And Andexanet is a recently developed antidote that can be used to reverse its action. Direct thrombin inhibitors. They are commonly used drugs and they are reversible inhibitors that can bind directly to both the free and fibrin-bound thrombin. The parenteral form of direct thrombin inhibitors is the vivaluridine. It's a very effective drug and is rapid acting, so it's very beneficial in acute insult. The T-half is short, kind of short, is only 25 minutes. Depends on the renal and hepatic excretion. And the oral direct thrombin inhibitor is the dabigatran. Dabigatran is a prodrug, and longer T-half is about 8 hours, and it depends on the kidney and its excretion. Dabigatran also, together with rivaroxaban, is one of the NOACs. The use of direct thrombin inhibitor, it is an ideal to control the HIT or HIT thrombosis because it acts directly on the thrombin, fibrin-bound thrombin, and also on the free one. It's teratogenic, it's not approved during pregnancy, and also contraindicated in renal disease if creatinine clearance is less than 30%. It does not have a regular monitoring test. There is an antidote called idarucizumab. It's a monoclonal antibody that binds specifically to dabigatran to reverse its action. And talking about the vitamin K antagonists, they decrease the hepatic synthesis of functional coagulation factors, عارفينهم اللي هما 2, 7, 9, and 10, by antagonize the vitamin K, which is essential for their activation. Vitamin K antagonist, the warfarin, has a high oral, about 100% oral bioavailability. It's highly bound to plasma proteins and has delayed onset of action, around 8 to 12 hours, but it has a long duration. Delayed onset of action because it inhibits the synthesis, so it takes time, does not blindly act, but it inhibits the hepatic synthesis, so it needs time. Because there is already active coagulation factor in circulation. So inhibition of its synthesis will lead to a delayed onset of action. It is metabolized by many hepatic cytochrome isoenzymes and this makes it subjected to serious drug interactions that we are going to explain. Warfarin crosses the placental barrier and has a very bad teratogenic effect. It's teratogenic. The mechanism of action of vitamin K antagonists of warfarin is that the factors 2, 7, 9, and 10 require carboxylation. These coagulation factors, when they are non-carboxylated, they are inactive. So it needs to be carboxylated to be an active, biologically functioning coagulation factors. How do you get this carboxylation? Is through the conversion of the vitamin K from its reduced form to its oxidized form. And at the same time, the oxidized form has to recycle back to its reduced form through the vitamin K epoxide reductase enzyme. Warfarin acts by inhibition of this epoxide reductase enzyme, so it inhibits the formation of reduced vitamin K2, which upon its oxidation, it gives the carboxyl group to the coagulation factors to activate it. So warfarin acts competitively. It's a competitive antagonist to the vitamin K epoxide reductase. For the warfarin to act, it needs 5 days, and this is the time required to inhibit the synthesis of the hepatic sense of coagulation factors, and until the already present coagulation factors in circulation are inactivated. So if there is a thromboembolic event, we start with giving both unfractionated heparin and warfarin at the same time. Unfractionated heparin will act as حاجة اسمها bridging therapy. It will overcome the latency of warfarin. And warfarin will work then to inactivate the clotting factors. طيب لحد امتى نستخدم الانفرactionated heparin? To day 5. At day 5 we withdraw the heparin, and then warfarin will start to act, and we monitor its action through the prothrombin time and the INR, the International Normalized Ratio. The adverse effects of warfarin, of course, the bleeding, it can be minor, and we can overcome it by adjustment of the dose, and it can be massive. In this case, we withdraw the warfarin immediately, and we give a fresh blood transfusion, and also we can give the antidote, the vitamin K1, to produce the active clotting factors. And of course, we can give a fresh plasma or blood transfusion. Warfarin is teratogenic, never used in pregnancy, and rarely can cause skin necrosis. It can interact with food and many drugs that can either increase its toxicity, so increase the bleeding, the bleeding risk, or decrease its efficacy, which increase the coagulation risk. The drugs modulating the response to warfarin can either drug that increase its effect, so the INR will be prolonged, such as the intestinal flora inhibition by oral antibiotics. Intestinal flora inhibits vitamin K, so it will promote the anticoagulation and can cause bleeding. The microsomal enzyme inhibitor use, which will increase its bioavailability by decreasing its degradation, such as rosuvastatin, clarithromycin, and allopurinol. The drugs that can displace warfarin from its binding sites and increase the bioavailability, such as salicylates, sulfonamides, or sulfonylurea. If warfarin also is co-administrated with drugs that increase bleeding, such as non-steroidal anti-inflammatory drugs, which inhibit the platelet function and can cause bleeding together with the anticoagulation. Also the use of together with heparin, it can increase the bleeding and prolong the INR. The drugs that can decrease the INR, so decrease the efficacy of warfarin, are the drugs that increase vitamin K, such as a lot of green leafy vegetables that has a lot of vitamin K can antagonize the warfarin. Drugs that decrease the absorption, such as cholestyramine, which can bind with it and decrease its absorption from the GIT, or drugs that can increase clotting factors synthesis, such as contraceptives and estrogen. Also, the drug that can induce the drug metabolism, which are called microsomal enzyme inducers, such as carbamazepine, rifampicin, and tobacco smoking, which will decrease its bioavailability. So coming to the NOACs, the new or the novel oral anticoagulants, the NOACs drugs, they are including the rivaroxaban, the factor 10A inhibitor, and dabigatran, the direct thrombin inhibitor. And they are meant to overcome the drawbacks, the adverse effects of warfarin, being it has been used that from a long time. It has been used as the only oral anticoagulant that exists in the market. So NOACs are important line of anticoagulation now, the oral anticoagulation, as it has many benefits over the warfarin, such as the rapid action, so it can be given as initial therapy. We don't have to use a bridging therapy such as the heparin with warfarin. It doesn't have a latency in action, so no heparin bridging therapy. Predictable anticoagulant response is very important. You do not need monitoring except طبعا لو في renal insufficiency will affect its excretion, but generally they can be given without the need of monitoring. And it has minimal drug or food interactions. And we are done with anticoagulants. Good luck, everyone.